Okay, good afternoon, Professor and all college. I'm Dr. Thân Văn Sỹ from Việt University Hospital. In the next few minutes, I will present a new technique for do RFA. Actually, it's not new, but I think it's uncommon in Vietnam. As we perform RFA under fluoroscopy guide for small subphrenic HCC. So, as we all know, percutaneous RFA has been widely implemented in the management of HCC, and most of the case we do under ultrasound guidance. But for some difficult situations, such as subphrenic nodular, is challenging for RFA under ultrasound guide. So, for this case, we have some techniques to perform RFA, such as fusion imaging guide or CT guide or even the fluoroscopy guides. But these techniques not always work well. For example, in this case, the patient suffer from anterior segmentectomy due to HCC, and now a nodular here, recurrence, and it's very difficult to puncture to do RFA. And even if we use fusion imaging here, we see clearly tumor on the CT, but on ultrasound, we're not sure that here is exactly the tumor to puncture and doing ablation. So, and another sorry. It not work. So for example, for this lesion, we have a nodule in the segment 6, and we do RFA under fluoroscopic CT guide. This technique is very useful to approach under with the axial planes, but for oblique approach like this, it's very difficult to puncture to the nodular. And for this case, normally we can do under CT guide like this, but normally it requires multiple puncture and repositioning to the electrodes to obtain the precise positions of the electrodes. And it also increase the risk of tumor seeding from the needle track. And recently we tend to move to the doing RFA under fluoroscopy guide, and we found that it's easily to target the lesions, regardless the location of the tumor. And so the aim of this study to assess the technical feasibility and local efficacy of the fluoroscopy guide RFA following stages for subphrenic small HCC. And this retrospective study, and during 2 years, we collect 22 patients with subphrenic small HCC with well-compensated liver functions, and also lesions are not suitable for RFA under ultrasound guidance. So we do combine ThS then RFA. And for this technique, firstly, we need to careful evaluation the imaging prior to the procedure and choose evaluate the expected electrode path. For example, in this case like this. And we also do ultrasound to confirm, check if it's possible to do RFA under US ultrasound guidance. If not, we do CTs to get with lapidodon, and so that the tumor can be visible on fluoroscopy, and then we do ablation under fluoroscopy guide, and here's and then for imaging follow-ups after 1 day and 1 month. For the first case, here we have a patient with chronic hepatitis B, and patients suffer from segmentectomy of segment 5 6 years ago, and after that multiple time recurrence chest with ThS. But here on the follow-up CT scan, we found a nodular here, a subphrenic ACC, small, but it's very difficult to puncture under ultrasound. And so in this case, we have this CT scan and check on the structure. And so that here is CT, the nodule supply by the subphrenic artery, and here's CT, and then we're not sure the tumor where it is. And here's a puncture under fluoroscopy guidance. And here's the US following during procedure, and here, I'm sorry, the video is not working. And we obtained complete the response after 1 month. And another case, here's patients suffer from, here we have a recurrent nodular after right hepatectomy, and the lesions surely is invisible on ultrasound. So with the same technique, we do CT first and then puncture under fluoroscopy guidance. And here, here's the imaging 1 day after procedure. We can see the ablation zone is covered all the tumor and a little bit pleural effusion here, but it's not much, and the patient has no symptoms, so he's discharged after 1 day after procedure. And another case we can see here, after right hepatectomy, a nodular recurrence at the left lobe and very near to the diaphragm, stomach, and the spleen. And for this, in this case, patients receives 2 times ThS, but the tumor is not disappear. So at this time, we try to do RFA under ultrasound, but we cannot find the nodular. So CT and then puncture under fluoroscopy guidance. Firstly, in the plane parallel to the electrodes, and when we touch to the nodular, we change the plane to the another view to confirm the negatives, and then ablation. And here's 1 month follow-up. We can see here the ablation zones cover all the nodular. So during 2 years, we have 22 patients, and almost patients are male with type A, and 23 patients with type B and under chronic liver disease. And for tumor size, is around from 1 to 3 centimeters, and the targeting time to the nodular is around 2 minutes, with ablation time around 10 minutes. And the technical success obtained in all patients, and the same with other study. No major complications were found in our study, and only 5 cases, a few of the minor complications, but the patients no symptom, and all discharged after 1 day. So in conclusion, the fluoroscopy guide of a following ThS is a safe and feasible instrument of subphrenic small CC, and we found that it's very easy to target the lesions regardless of location, and it should be considered as a viable guiding options for combined treatment. Thank you.
Okay, thank you. Your presentation is on time, so I have a small question. In case you could not do the TACs for the subphrenic lesions, is there any other option to do the RFA if you could not see it on the ultrasounds? How about the cone beam CT?
Yeah, actually, the cone beam CT, we can use for scale. We cannot do stains. Stains possible. The tumor is invisible on the fluoroscopy, so we could not be used this technique. For this case, we can do SACT to the cone beam CT with injection, so we can find the nodular or and maybe we use this data to fusion with echo ultrasound to do, or if not, maybe do RFA in intra-operation. Yeah.
In your series, you have 15 cases with the TAC first, and it means that 7 cases without TAC first. So what's about different reason? And also for, because lesion is small and nearby the diaphragm, so what about, do you have any technique for avoiding the lesion of the diaphragm?
Yeah, actually, in our study, all patients receive the TACE first, then RFA. And for the techniques, I note that because I cannot, the video is not played, but firstly, to puncture, firstly, we need to use ultrasound to check if there are any structure or major vascular, major vessel could be in the needle tract, and we use the ultrasound to sure that we do not puncture to the gallbladder or hollow organ, and then in the plan parallel to the needle tract, I punch to the tumor and we move a little bit the needle during puncture. So when the tumor is moved, it means the needle touch to the needle, and we change other plan and then advance a little bit carefully and see the needle tips touch to the distal border of the nodula. That's the answer.